Αγαπητοί συνάδελφοι, εγώ το Προεδρείο, ήθελα να σας καλωσορίσω και εγώ εκ μέρους της Οργανωτικής Επιτροπής. Dear colleagues, I would like to welcome you to the second Athens shoulder course. Today, I will talk about the posterior shoulder dislocation. The shoulder is has the greatest range of motion in the body. It has motion in all three planes of movement, and it's prone to instability. It sacrifices stability for mobility. What is instability? Well, it's a biomechanical dysfunction. It's failure of static and dynamic stabilizers, and it ranges from mild subluxation to traumatic dislocation. The static stabilizers are the ligamentous structures, the labrum and the capsule, while the bony configuration of the glenoid and the humeral head play an important role. The dynamic stabilizers is the rotator cuff and the scapular muscles. The capsule, it seems that the inferior glenohumeral ligament plays a significant role in the extremes of internal humeral rotation. The posterior capsule, not like the anterior capsule, is very thin and it has less clearly defined ligamentous components, and especially above the equator. Now, the glenoid, it seems that the greater the retroversion of the glenoid, the more prone it is to posterior instability and dislocation. The rotator interval, it also seems to play an important role with the humerus in neutral rotation. Harriman showed that incision of the rotator interval capsule increased posterior translation by 50% and the inferior translation by 100%. The posterior labrum, that when injured can have a posterior Bankart lesion or a Pobsler lesion. Subscapularis, well, it's a dynamic stabilizer and it seems to provide the greatest resistance to posterior subluxation of the humerus. Here is you can see a picture of a posterior inferior Bankart lesion. Etiology. Now, we have atraumatic instability, so when we have no history of true dislocations. We can have a history of minor trauma or repetitive microtrauma, usually in sports, and usually it is associated with capsular laxity. Traumatic instability, dislocation or subluxation usually sustained during significant injury. Now, atraumatic posterior instability, usually not always is a loose joint individual. We can have frank dislocations with minimal violence, often reduced by the patient. We can have subluxations or positive apprehension sign in forward flexion and internal rotation. Also, we might just have posterior pain or a clicking and functional impairment in flexion and internal rotation. It's quite common seen in boxers, but also we can see it in weightlifters, throwers, racket sport athletes, rugby players, and swimmers. Traumatic posterior dislocation, well, it was first described by Hippocrates. Also, Sir Astley Cooper in 1839 first described a patient with posterior dislocation after a seizure, and Magdalene first described a series of 37 patients with posterior instability in 1855, before the advent of radiology. Now, posterior dislocation is very rare. It actually consists 2 to 5% of all shoulder dislocations. It may be difficult to diagnose, and it's often missed up to 50% on standard AP views. Etiology is high energy trauma, epileptic seizures, or electric shock. It's caused usually by a force applied on a flexed, abducted on internally rotated arm. And in cases of seizures, it can be, or electrocution, it's caused mainly because the internal rotators are twice as powerful as the external rotators, so a sudden contraction will cause the head to dislocate posteriorly. Lesions that can be found are a reverse Bankart lesion, a reverse Hill-Sachs lesion, lesser tuberosity fractures, posterior Hangler lesions, or a Pobsler lesion. On clinical examination, attempted adduction and external rotation are painful. Abduction, sorry, and external rotation are painful. And the arm generally cannot be externally rotated past the neutral position. It might resemble a frozen shoulder, and usually we don't have any nerve or vascular injuries. So, caution, lot posterior dislocation is easily missed. This is a patient that came to our clinic 1.5 months after having a posterior dislocation. You can see he is still in posterior dislocation. He can forward flex, he can internally rotate, but he can't externally rotate beyond the neutral position. And you can see a 3D CT scan. Another patient is 10 months posterior dislocated. His shoulder is dislocated here. You can see the CT scan. He can forward flex and internally rotate quite well. Another patient in 1 month with a locked posterior dislocation. You can see a sign anteriorly, the shoulder is empty and it protrudes posteriorly. You can see also the CT scan. So imaging, how do we recognize it? We do X-rays, CT scans, 3D reconstruction, MRI or MRI arthrogram. On the X-rays, it's important. Some helpful radiographic signs is the light bulb sign, where the humeral head, because it's internally rotated, the tuberosity no longer protrudes laterally. Also, the through line sign, where you can see two parallel lines. One is the medial cortex of the humeral head, and the other one is from the impaction of the reverse Hill-Sachs. CT scan, nice pictures on 3D reconstruction. You can also see posterior dislocation. So now what do? We have to decide what we do. It depends on the functional status of the patient, the time elapsed between the injury and the diagnosis, the glenoid defect if there's one, the size of the reverse Hill-Sachs, the condition of the articular surface. Then very few evidence-based protocols for treatment. So soft tissue injuries, we usually need to repair a posterior Bankart lesion or a capsular labral repair. If there's no Bankart lesion, we might need to do in a hyperlax posterior capsule, we might need to do a capsular shift. For bone defects, so if we have a reverse Hill-Sachs lesion, we can do a transfer of the subscapularis tendon. It's a McLaughlin procedure. We can do a transfer lesser tuberosity, rotational osteotomy of the humerus, an allograft reconstruction with a bone block, glenoid osteotomy if we have a retroversion more than 20 degrees, or even a shoulder arthroplasty. Treatment options, we can do open surgery or arthroscopy. Well, arthroscopic surgery has advantages. It has lower morbidity. It's easy to access the entire joint and treat any associated lesions, and it's easy to revise. How do we make it easy? Well, the only thing we have to do compared to anterior Bankart lesion is we have to reverse the portals. In our department, we actually treated 10 posterior dislocations in 3.5 years, and 8 patients presented with their locked posterior dislocations. They all had been treated initially in other hospitals with immobilization, and they had been misdiagnosed as having soft tissue injuries. All these patients had road traffic accidents, and the average interval between the traumatic event and the operation was 2.7 months. And they had mild to moderate pain with no neurological deficit. You can see preoperatively, the forward flexion varied, but all of them had no external rotation. We did preoperative imaging, X-rays, CT scans, MRI scans. We had no fractures of the humeral head, no arthritis. 7 out of the 8 patients had a closed reduction under general anesthesia. 1 patient we didn't manage to reduce closed, so we had to do an open reduction, and then we proceeded with an open McLaughlin procedure. The other 7 patients we actually treated arthroscopically. Here there are some pictures you can see. We are looking from the anterior superior portal. So this is a posterior Bankart lesion. This is a reverse Hill-Sachs lesion. Sorry. So looking from anterior superiorly, that was the reverse Hill-Sachs lesion. And then after, we can see here, a reverse Hill-Sachs. So what did we do? For reverse Hill-Sachs lesions, we abraded the lesion, and then we actually did a tenodesis of the subscapularis tendon using 1 or 2 anchors, depending on the size of the lesion. Here you can see the tenodesis of the subscapularis. So for posterior Bankart lesions, we mobilized the posterior labrum using a shaver or a vapor and placed 2 to 3 double-loaded anchors, depending on the size of the lesion, starting always from the lower part of the lesion. And in the cases that we had a very lax capsule, we did also application. Here you can see the placement of the anchors. Now, postoperatively, we put the patients in a brace, 30 degrees of abduction on neutral rotation for 6 weeks. We allowed the patient to remove the sling for exercises and simple activities of daily living below the shoulder level. So the first 3 weeks, we did mainly pendulum exercises, scapular, hand, and elbow range of motion. After 3 weeks, we went on from passive progressively to active assisted exercises, but we restricted the patients to do no internal rotation and abduction for the first 6 weeks. In the first 8 weeks, the goal was to gain the full range of motion, as well as gain scapular stability. After 8 weeks, we went on strengthening exercises of the shoulder. All patients regained full range of motion, functional range of motion, between the 8th and 16th weeks. During the same time period, we went advanced strengthening exercising program that included isotonic concentric ascending loading exercises. No patient actually developed any stiffness. Overhead activities, we started after 3 months, on contact sports 6 to 9 months, depending on the progress of rehabilitation, the level of participation. This is a patient 3 months after the operation. You can see now he can externally rotate, has a full range of motion. This patient has a bit of restriction in internal rotation, but he can fully externally rotate. So take-home message, posterior dislocation is a very rare injury. Be suspicious if there's no external rotation, if the other movements are possible. Look for radiographic signs. In any doubt, ask for a CT scan. For unidirectional posterior shoulder instability is much less common than anterior instability, and it should be strongly suspected in those high-risk group of athletes with posterior shoulder pain and/or clicking. Arthroscopic treatment is a reasonable treatment, even if for locked posterior dislocations. If closed, reduction, of course, is possible, and we have good results, and can easily address associated lesions. Just remember to reverse the portals. Thank you.